Alright guys, let's get busy talking about benzodiazepines. Short word for this is benzos. I might use that a lot here in this talk. So benzos have a lot of clinical utility, but they also have the capacity to be extremely addictive. So I want to talk about their clinical utility and their addictive potential here. And let's start out with the mechanism of action. So it's all about increased GABA A agonism. And we know that GABA A agonism happens in alcohol, happens in benzos, and happens in barbiturates. So it's important to realize that GABA A is really important because all these three things, alcohol, benzos, and barbiturates, all have deadly withdrawal symptoms, and that's because they're all GABA A agonism. And that's how I kind of like to lump these together, but it's also important to be able to figure out the differences between them. So when it comes to benzodiazepines, they have GABA A agonism. This causes increased chloride channel opening frequency. Now, this word frequency is in bold, and it's so important, guys. I cannot emphasize how important this word frequency is. I'm going to highlight it like 5 times. And this is because benzos and barbiturates have a very similar mechanism of action. The only difference is that here in benzodiazepines, we have increased chloride channel opening frequency, whereas in barbiturates, we have increased chloride channel opening duration. And they love to ask about this mechanism on step 1, so I really want to pound it in for you guys. At the end of this whole chain of events, this increased frequency of chloride channel causes decreased neuronal firing. So what does this mean clinically? This is going to cause patients to feel more relaxed, less anxiety. It's going to cause a decrease in fear. It might make them feel a little bit sleepy. It might help them have trust in you as a provider. There are a lot of effects. It's also going to be a great agent for seizure prophylaxis. So when we have a patient who's coming in who is actively seizing, benzos are almost always going to be the first line agent because they really don't have a lot of major adverse effects in the acute setting. What we worry about is their addictive potential. So let's talk about short-acting versus long-acting benzodiazepines. So our short-acting, I'm going to highlight in yellow, and this is going to be alprazolam, triazolam, oxazepam, and midazolam. I want to give you guys a great mnemonic for remembering these short-acting benzodiazepines. So I'm going to highlight the first letter of each word. So A-T-O-M, and that spells out atom. So that is how I remember the short-acting benzodiazepines, because if you remember the first letter of each one, they spell atom. When it comes to our long-acting benzodiazepines, it's just going to be all the drugs that have a letter that does not fit into atoms. So this is going to be flurazepam, lorazepam, diazepam, and then the one that doesn't sound like any of the rest, chlordiazepoxide, which is also called Librium. So in terms of recognizing a benzo on exam day, I want you to notice that they pretty much all have the same ending. It's like this kind of olam ending, epam, olam, epam. So that's how you're going to recognize them all, except for Librium, which is chlordiazepoxide, which is really hard to say, but usually I just remember it because it's so weird sounding that I can remember that it's the one benzo that doesn't really fit in with the rest. Let's move on to talking about how our benzodiazepines are going to be metabolized, because this comes up a lot on test day. They like to sneak in these extra hard third order questions. So the metabolism is variable based on the agent that we are using. Let's start out by talking about our liver independent metabolized benzodiazepines. And so these are going to be oxazepam, triazolam, and lorazepam. Now let's talk about our liver-dependent benzodiazepines. So it's going to be alprazolam, midazolam, flurazepam, diazepam, and the tricky one, chlordiazepoxide. Let's move on to talk a little bit about our clinical uses. We kind of mentioned this already in the beginning. I'm going to go back to our blue highlight color because it's very cool and soothing and calming, and that's what I think about benzodiazepines. So they're great for anxiety and panic disorders, really in the acute phase. So if someone's having a terrible panic attack, we usually try to use conservative calming measures like breathing exercises and grounding the patient in reality. However, you can use a benzodiazepine to give an acute calming effect, especially if a patient is extremely agitated and it may be dangerous to staff. However, benzodiazepines are almost always going to be a second line option for a patient who's anxious or agitated. We want to use conservative measures first. Additionally, they can be used in insomnia, but remember from our insomnia episode, we talked about it's always important to eliminate the primary insult that could be causing insomnia first. So like caffeine or shift work or a proper sleep schedule or other things that could be causing people to have insomnia. Benzodiazepines are not a great choice. It's more of a second or last ditch effort to get someone healthy sleep. When it comes to sleepwalking, benzodiazepines are really helpful because remember, benzodiazepines shorten the N3 phase of sleep. And N3 phase is when sleepwalking occurs. If you'll remember, we had the mnemonic about N3 is E, which is like sleepwalking. So if benzos shorten N3, it shortens the window in which a patient can sleepwalk. So this is why they are really useful for patients with sleepwalking. Additionally, they're great for alcohol withdrawal because remember, we talked about our GABA A agonism, which I'm going to really highlight deeply up here in the top, and how GABA A is shared between alcohol, benzos, and barbiturates. So if we have a patient with alcohol withdrawal, we can give them benzodiazepines in order to prevent delirium tremens and those life-threatening symptoms. So those are usually going to be the first line for our patients who are in active alcohol withdrawal. Additionally, we said we can use this for status epilepticus as a first-line agent, and it's also great for muscle relaxation. If a patient has a muscle spasm or is feeling incredibly anxious about a car crash or something like this, a benzodiazepine would be a great choice here. Let's wrap up by talking about some of the complications of benzodiazepines. So we talked about the fact that patients can develop dependence. And an increased risk of this is going to happen to our patients with short-acting benzodiazepine use. So that's going to be those that are going to be our ATOM, ATOM benzodiazepines. We talked about GABA A lot today. So GABA A is the same in alcohol, benzos, and barbiturates in terms of being agonized by those three agents. You can imagine that if you were taking two or more of these agents at the same time, they would synergize their activity. And this is really scary because we get agonism that synergizes the depressive effects of alcohol and barbiturates if they're taken alongside of benzodiazepines. And this can cause life-threatening depressive effects, and you never want to mix these agents. The symptoms of patients with too much GABA A agonism that we're really worried about is going to be respiratory depression. So if we have a patient with severe respiratory depression from alcohol or barbiturates or benzodiazepines, there is an antidote that we can give specifically for the benzodiazepine component. And this is going to be flumazenil. And it works by being a competitive antagonist at the GABA A receptor. And what this does is it basically knocks off all the benzodiazepines off of that GABA A, and it can relieve the symptoms of respiratory depression. However, it can also precipitate seizures. Because remember, we're really worried about seizures in patients who have GABA A agonism who are in withdrawal from one of these three agents. So we really want to avoid using flumazenil in patients with excessive benzodiazepine dependence because we could precipitate a life-threatening seizure in an attempt to help them with their respiratory depression. So more likely it would be a better idea to go ahead and intubate this person or provide them with respiratory support instead of giving them flumazenil and precipitating a seizure. So I just wanted to mention that we have the risk of seizures with acute withdrawal when we give flumazenil, which is going to knock off the benzodiazepine off that GABA A receptor and lead to these withdrawal symptoms.